Afternoon, good evening. I extend a warm welcome to all people who are joining us in special webinar number 141, organized by the Andean Health Organization Hipólito Unanue Agreement. This cycle of webinars began in May 2020. This year, we're celebrating 50 years of our Andean Health Organization, a very sensitive and significant anniversary due to the difficult times we're going through. However, as a reference in health in the region, we continue uninterruptedly the joint and coordinated actions with the 6 member countries: Bolivia, Colombia, Chile, Ecuador, Peru, and Venezuela, thus fulfilling the goals and objectives to strengthen the health of our people. A reference in health, we would like to highlight that vaccination against COVID-19 is safe and effective in protecting ourselves and others. The more people who are immunized, the less likely they are to become infected. Make sure you and your family receive the second, third, or fourth dose as appropriate. So there is no excuse for not complying with the COVID-19 vaccination schedule. Yesterday, September 28, we celebrated the World Day against the fight against rabies, and we have the Andean Week of Rabies vaccination in 11 border areas that will be carried out between September 28 to October 21 of this year, in order to eliminating the risk of transmission of rabies both in humans and dogs. Take your dog for vaccination and protect your family and your community. The socioeconomic and environmental context in Latin America and the Caribbean is a scenario in which hunger, food insecurity, and malnutrition have increased. Policy decisions are required to achieve sustainable, sufficient, inclusive, efficient agri-food system that generate equal access to a healthy diet for all. Climate change threatens life, health, and well-being. However, we can contribute to its preservation from wherever we are, generating social and sustainable development model by joining an initiative in defense of the environment, buying local products and plant-based foods. We can use public transport, cycling, or walking, as well as reducing consumption by reusing, repairing, and recycling. It's everyone's duty to restore the relationship with nature. It is necessary to recognize the ancestral knowledge of native peoples who have lived in balance with Mother Earth and practice good living. Well, in accordance with the above, today, Thursday, September 29, we open our virtual doors to discuss a topic of great importance for our region: update on vaccination against COVID-19. We invite you to leave your name, organization, and country from which you are joining us through the comment box on the Facebook Live or YouTube Live chat. Same space, you can leave your questions or send them via email to webinarhorasconju@gmail.com. To access the certificate of attendance in this webinar, as usual, you must fill up a short survey and leave your data in the fixed link found in the Facebook Live or YouTube chat. The certificate will be sent to your email in the next days. This webinar will be developed with the usual dynamics. We will start with the institutional greeting, then the presentations of our speakers, the active pause, and the space for Q&A. begin this important day, I give the floor to Dr. Marisela Malki Osorio, Deputy Secretary of the Andean Health Organization, who will give the welcome and institutional greeting. Go ahead, Dr. Malki, you have the floor. Thank you, Lucho. Good morning, good afternoon to all of you who are following us in this webinar about update on COVID-19 vaccination. Remember that the Andean Health Organization Hipólito Unanue Agreement is an sub-regional integration institution and the referral in health for the Andean sub-region. In last December, we celebrated 50 years of uninterrupted effort with the 6-member countries Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela. And since May of last year, of 2020, we are promoting these spaces of interlearning in the context of the pandemic to disseminate, analyze, and manage information with solid scientific evidence that contributes to decision-making in our sub-region. As we remember, in December 2020, vaccination against COVID-19 was initiated, when a total of 84 million cases and 1.7 million deaths had accumulated worldwide. In the Andean countries, there were, at that time, 3.3 million cases and 100,000 deaths, which brought a great impact on the population, where a growing number of cases per day, deaths per day, and overcrowding in health services. In May 2020, South America became the global epicenter for the pandemic and remained in this situation throughout the year 2021, which made evident the urgent need for vaccines to reduce the risk of illness and death. Currently, vaccination with 2 doses places South America in the first place in the world with 77% of vaccinated people, followed by Asia with 72%, Europe with 66%. And in booster doses, we have a 63% of our population vaccinated, being evidence of the high acceptance of the vaccine by our countries. But when we evaluate the coverage within each country, we find a situation where the elderly, vulnerable by non-communicable diseases, are still not adequately protected. To date, we have a total of 10 different vaccines, and we have 12.5 billion doses applied in the world. However, for the Latin American countries, the road has not been easy. In January of 2021, the ECLAC showed that only 11% of the 6.5 million doses of vaccines available at that time worldwide were available. This situation should never be repeated. And we must strengthen our capacities to have autonomy in the production of vaccines and a better capacity to negotiate the new vaccines against coronavirus are to emerge. Scientific evidence from a number of investigations around the world has shown that vaccinations against COVID-19 produces a highly protective immune response and provides a more predictable immune response than infection by the virus itself, and that it offers additional protection to people who have already had a disease, which has been called hybrid immunity. In the case of people who have already COVID-19 and who did not and were not vaccinated, after recovery, they had 2 times more likely to be reinfected with COVID-19 than those who received the full vaccines following their recovery. So, getting vaccinated can protect people around you, especially those at higher risk of becoming seriously ill due to COVID-19. Reduces the risk of suffering the post-acute COVID syndrome and avoid having the sequelae that are a matter of concern because they generate chronic diseases that may be permanent. Therefore, we promote prioritization of vaccination in older adults, especially those who suffer from chronic diseases such as obesity, heart, kidney, and lung diseases. The vaccination should be maintained for people with immunodeficiency and health workers also who are the first line of responders in our health facilities. Learn about international experiences of the advances in knowledge, impact of immunization. We have invited professional experts such as Dr. Patricia Minaya Flores from the High Authority of Health of France, Dr. Azra Ghani, researcher from the Imperial London College, and Dr. Ernesto Ortiz, researcher from Duke University, the US, whom we thank them in advance for your participation. Once again, welcome everyone to this webinar. Thank you, Lucho. After the greeting of our Deputy Secretary, I introduce myself. My name is Luis Bengolea Moore, medical epidemiologist, coordination of border health and thematic areas, and I am pleased to be in charge of the moderation of this webinar. On this occasion, we are joined by experts, international experts, who will participate. And after this preamble, we will begin the event with a warm welcome to Dr. Patricia Minaya Flores. She is head of the Department of Public Health and Vaccine Evaluation of the French High Health Authority since 2021. Prior, she has served as scientific project manager at that same institution and as a consultant to the French Public Health Research Institute. Welcome, Dr. Patricia. You have the floor. Good morning. Thank you very much for your invitation. It's a real pleasure for me to be here with such excellent presenters and to address the Latin American audience. Indeed, today I will talk about the validation process for vaccines, considering the efficacy and safety. Thank you very much for the opportunity. Before starting to talk about vaccines, I would like to perhaps clarify and remind everyone that the vaccination strategies and the vaccination programs are not a perfect weapon. It's not the absolute response to all these, to any of the diseases. In fact, in the pandemic that are caused by respiratory virus. This is an additional intervention that adds to all the existing interventions, including those who are personal responsibilities and those are collective responsibilities, as it's being presented by this Swiss cheese model, where we see that each layer has holes because, once again, no intervention is perfect, and is overlapping these layers that we're going to have the best efficacy of the entire program that needs to be put in practice to fight against these respiratory viruses. We talk about vaccines. The first question that's quite appropriate and many people ask themselves is, while historically or traditionally the validation of vaccines took 10 years as an average, in the case of the COVID-19 pandemic, we could validate them so soon. Five major elements that I would like to mention and explain so we can all be aware of what have lead us to validate them in such a short time. And as I mentioned, the Institute Secretary mentioned, have them available by the end of 2020, while the pandemic started in January of 2020. Well, the first reason is that financing was almost unlimited. Remember that at that moment, in the months of March, April of 2020, many of us were isolated, confined, most countries, and the world economy had come to a halt with catastrophic consequences for many populations and countries throughout the world. And that implied that all the institutions and international organizations that were looking for solutions, and one of them was vaccination, and therefore the was unlimited financing, both from the state or governments who invest in this investigation, as well as the international organizations. Because when a pharmaceutical group decides to start a research plan in order to develop a vaccine, the first phase is to look for this funding and has to demonstrate that the vaccine candidate covers a need. In the case of COVID-19, all the parts could fund this, provided almost in 100% for the development of vaccines against COVID-19. Another thing is that it's all the RNA vaccines have been mentioned continuously, indicating that this is a novel technique. It's used for the first time, and it is true that we have the first vaccines with this messenger RNA platform, but we need to know that this platform had already benefited for many years of research and attempt and trials to be used in different pathologies. At some point, it was believed that it was a technique that had no future because the messenger RNA is quickly destroyed inside the human body, but the usefulness that has received recently in the scope of vaccines was quite beneficial, and it's been proven that they are useful and effective in the case of COVID-19, and is perhaps a vaccination platform that's going to be used towards other diseases that may be prevented with vaccines. The other two topics are very closely linked. The fact that the volunteers for clinical trials that were started were very big in size in Latin America, and several countries participated in these clinical trials. It's important to know that the registration was done online and that the thousands of people needed for these studies was filled in minutes, when it usually is a phase that takes months in order to recruit volunteers on other type of studies. And this is also linked to the fact the disease had a high prevalence. The virus expanded quickly, and the fact that have volunteers, many volunteers who participated in the trials, added to the circulating virus, allowed that the clinical trials could get results much quicker. In a few moments, I will explain how we can compare two groups. But in any case, what we're looking here is to show the difference between the two groups based on different evaluation criteria. And not the same to do an research for a disease such as AIDS, where there's not has a high prevalence, where this is not a respiratory virus that's going to expand quickly, versus COVID, where cases and severe forms of disease may be quick spread. And the last factor of why could evaluate these vaccines is the fact that very good communication channels. Now we have communication bridges between the different manufacturers and institutions and regulatory agencies throughout the world, like the FDA in the US, the EMEA in Europe, and agencies such as the one for our work, which is the high authority of French health in charge of defining the place where a vaccine has within a vaccination strategy that has been previously described. So, while before the pandemic, we waited that the manufacturers produce or generate their trials and obtain their results and publish these results and submit their the file list on the different agencies took months during the COVID-19, during the entire COVID-19 pandemic, and for the evaluation of the new variations of messenger RNA, communication has been so fluid and quick that the results have been issued in very short times, counted in days or even hours, if we compare to what existed before. And a final topic that I don't usually mention is that there has been many people that have offered their free time and that have worked days and nights, weekends, holidays, in order to carry out the research and evaluate the clinical data and to issue recommendations at the national and international level to face this pandemic. When we evaluate vaccines, what do we need to consider? I will explain later in what clinical phases these are relevant. Well, the first one is the immunogenicity, where we measure the antibody, neutralizing antibody titers, and what is the cellular response that a vaccine may elicit in people or in animal models, depending on the clinical phase that we are going through. Then we look at the efficacy, and this is the ability of the vaccine to prevent the transmission of symptomatic forms or severe forms or death, depending on what is the goal of the vaccination, followed by the tolerance. That is one of the aspects that is taken into consideration because it's the balance between benefit and safety, which will determine who accepts or reject the risks of a vaccine, knowing that in life there's never zero risk. There are always undesired side effects that may occur, and these can be at two levels, the local or systemic side effects. This safety, this tolerance is evaluated during the clinical trials and continues to be evaluated later on. And we've seen that in the case for the COVID-19 vaccines, most of the side effects have been local side effects that indicate that they just indicate that their body is reacting to the antigen we're receiving. And finally, acceptability is also an important part of the evaluation. Another the most important aspects of these four, given that in the case of COVID-19, the health authority issue a preferential recommendation for RNA vaccines because of the good efficacy and a very good tolerance, an excellent one in terms of 94 to 95% against first strain, the original Wuhan strain. While when we evaluated vaccines, we accept an efficacy starting from 50%. So we could very well have decided to use these two vaccines only. However, in terms of acceptability, we had a part of the population who didn't accept it and didn't want to benefit from this type of vaccines because there's been case of other type of vaccines with different platforms and more traditional vaccines, so they can be used by those people who didn't want the per vaccine because in terms of efficacy and tolerance. Let's talk about clinical trials. The clinical trial phases are very important and something that needs to be clarified despite the fact that we have compressed different steps, as I mentioned at the beginning, with regards to the entire process of evaluating a vaccine. Phases have been respected. All the vaccines have had clinical phases where the vaccine is formulated. We do studies in animals, and then we move on to human studies in phase 1 to phase 3, where the groups increase and we determine what is the dose to be used. In the case of phase 1, we look at the immunogenicity criteria that I presented to you before. And then we go to phase 2 and 3, where once the dose has been established, we evaluate the efficacy and we continue considering the evaluation about tolerance and what the side effects observed in people who participate. And then you have phase 4, known as pharmacosurveillance, that we see in every country in order to continue monitoring the effects that are seen as extremely uncommon, and because of its low frequency, it could not be detected in the previous phases, because when we see adverse effects of one case in 100,000, while we haven't vaccinated 100,000 people, this common effect is not going to be seen. So phase 4 is focused on continuing evaluating and monitoring the effects that the vaccines may generate in a large population. I'm not going to go into detail of what are the different types of vaccines, but you can see that the Pfizer vaccine with bivalent adapted vaccines are based on nucleic acids on messenger RNA, and approved vaccines in the world as of today by different levels and not necessarily in all countries in the world. But in total, we have 30 vaccines that have received at least one approval from one country based on phase 3 studies and now being used in a larger population. I wanted to explain you how we perform a clinical trial. At a very basic level, it consists on a random distribution based on chance, select a group of voluntary in two groups, to which the first group we administer placebo So they get a substance that is not active. And the second group receives the candidate vaccine. And after a specific time, we look at the level of protection that the vaccinated group has presented. And we expect that if the vaccine is going to work, that the risk of being infected or developing severe forms of death should have to be inferior in the vaccinated group. And since the person who administers the vaccines or the person who received the vaccine knows what they have received, is placebo or the vaccine, this allowed us to obtain reliable results that allow us to evaluate the efficacy of the vaccine and all the effects described by the study participants are consideration and are part of the database and the information that the investigators are going to collect on a daily basis in order to make the final analysis. And nowadays, as been mentioned before, there are more than 12 billion doses of vaccines administered throughout the world. We see the coverage rates in the world as of yesterday. This has allowed us to have very reactive pharmacosurveillance systems that have allowed us to realize what have been the adverse events or effects, and in what group of the population these were more frequent, to adapt our recommendations according to the, or depending on the optimal way of proposing the vaccines to the group that's going to benefit more with the vaccine with the lowest possible. We're talking about an update on vaccination. You need to consider, or I would like to explain how these messenger RNA vaccines work. This is going to allow us to understand what are we talking about the new vaccines. And I say new, quote unquote, because the vaccines that were approved at different levels based on messenger RNA, those from Pfizer and Moderna, that have been validated based on all the clinical trial phases that I mentioned. So we have these three before receiving the authorization to be marketed and have benefits for more than 2 years of phase 4. And I will explain them quickly how they work to understand what has changed in them, what has been the variation, why do we have bivalent vaccines that not only to the original strain, but also to the variants that are actually circulating, which are the Omicron. I like this metaphor of the book and photocopy because it allows to understand how messenger RNA vaccines work. In the screen, you see the virus of SARS-CoV-2, which produces a COVID-19 disease. And we see that there's a part of this part of the virus we call the spike glycoprotein, like spikes that are seen in the viral capsule. In the RNA messenger vaccines, what they give the body as information is the coding for this protein, so our body can generate things. The virus will be like the book, and the vaccine is like the photocopies, not of the old in total pages of the book, but only the ones that provide instructions to reproduce and replicate the exact protein spike of a SARS-CoV-2 virus. And our body reads this photocopy, follows the instructions, produces spike proteins, and generates antibodies that are going to defend us against this protein. Photocopy is finally destroyed, because, as I mentioned, the messenger RNA is a substance that quickly breaks down in the body, has very few hours of life, and then our body that has already produced antibodies against the spike proteins, the next time, at some point in its life or in the coming months, is infected again or finds this real virus again, the SARS-CoV-2, it will recognize it because it has information that if it sees a spike protein, it has to attack and defend itself. So we are going to be protected against this virus. What has changed with the Wuhan and Omicron, and today we have two types, BEA1 and BEA145, is that the information that the vaccine carries inside is not the messenger RNA initial virus, but it is an RNA that codes for our body to generate spike proteins of this new variant. Today, several countries have validated Comirnaty bivalent of Pfizer and Moderna, and the Omicron BA1 and BA45 from Moderna. There are some countries that have decided to buy vaccine against BA1 because the circulating variant that we see at least in France in more than 90% is the BA5 variant. However, because this is a variation and not a validation of a new vaccine, the studies that have been performed and generated in order to have a quick availability of a vaccine adapted to the circulating strains, not been studies in the human phases, that is in the preclinical phases, and what has been studied, the immunogenicity. So studies have compared how the vaccine to Wuhan, what is the immune response that it generates, and if this response is higher with the different candidates, because the manufacturers were not only testing bivalent vaccines of Wuhan and Omicron BA1, BA45, but many other variants. If the immune reaction is larger or greater, we expect that the efficacy of these vaccines is at least the same, or in best case, better than the protection that is transferred with the initially developed vaccines. In the case of tolerance, the adverse effects, the local reactions are very similar between the two vaccines. The only thing that has changed is the antigen. It is expected that safety is exactly the same as of the initial vaccines. And finally, we are in a not in a post-COVID world in the sense that the pandemic is over, but in the sense that we have learned so much with COVID-19, and now is the time that we accept that this virus is here to stay, that we should face it, and that the waves are going to be consecutive, perhaps with the same schedule as flu, and hopefully it will come into a seasonality, but we have to update the vaccines as soon as possible and go into a model closer to that of influenza, where we decide what are going to be the strains that are circulating throughout the world in order to decide what vaccines are going to be used in each period in the Northern Hemisphere, in the Southern Hemisphere. It is also very good news that the pharmaceutical industry can quickly adapt with the circulating variants vaccines that they have already produced, like they do in the case of the flu vaccine. And as soon as these variations are used, the pharmacosurveillance will be activated so we can make sure that there are no common side effects that emerge with this variation, which is extremely very unlike. I thank you very much for your attention, and I'm ready to respond all the questions at the end of the meeting. Thank you so much. Thank you, Dr. Patricia. It's been an excellent presentation. You've made a summary of the validation process for a vaccine, but it was done at a critical moment in 2020, and due to the emergency, all the humanity interact to deal with that contingency that was generating a large number of deaths, as well as the affected population in every country in the world. You have indicated first the solidarity shown to improve access to information and also to share information among the institutions that at that moment were preparing a response through vaccines. And also you indicated the will of people to desire to participate as volunteers in the early studies to evaluate the efficacy of the vaccine. This has been an important step and also had funding that was required in order to obtain a quick response. You also mentioned what were the possible or what are the possible type of vaccines that are being used in the phases that has been accelerated from the initial phase until phase 4, so we can have vaccines available. These in which the information was transferred has allowed a better surveillance. Now, with regard to the bivalent vaccines, you've been very precise in establishing the characteristics of the two vaccines that are currently available, the Pfizer and Moderna vaccine, have the old strain content from Wuhan and the new Omicron strain in these different subvariants. Very kind in participation, and we'll have now the questions at the end of the meeting. Thank you, and we would like to invite Dr. Azra Ghani. He is head of infectious disease epidemiology at the School of Medicine, in the School of Public Health at the University at the Imperial London College. Her research combines the use of mathematical models and statistical methods to understand the transmission dynamics and the control of a variety of human and animal infectious diseases. She has a recent paper in The Lancet on the global impact of the first year of vaccination against COVID-19. Welcome, dear Dr. Azra Ghani. You have the floor.
Thank you very much, and thank you for inviting me today. I'm hopefully going to follow on very nicely from the introduction that Dr. Flores has given, which has given you all a good background to the current status of vaccination against SARS-CoV variant, COVID-2. So as we're all aware, I won't go too much over this, we're all aware of the current state of the COVID-19 pandemic. We're likely to have high levels of the virus circulating worldwide in the years to come. And the Omicron variant we now know is dominant across the world, but of course is continuing to mutate. And because of this, it is unclear whether new variants may emerge. We of course know that vaccination provides the best population protection, and therefore many countries, or all countries, are including some level of continuation of their vaccine programs. And the question that arises is, what strategy should countries pursue for longer term vaccination? For example, how frequently is boosting going to be required? Should we be doing yearly boosts of all age groups, or should we just be focusing on priority groups at highest risk? And of course, I won't touch too much on this, but there'll be a lot of question about switching to the new bivalent vaccines, either against BA1, 2, or against BA4, 5. And what's the value of these, and to what extent will we need these updates to continue in the future? And these are all questions that we're going to be grappling with for many years to come. So the way that we're approaching this is through using mathematical models to try and understand at the population level what the benefit is of different vaccination strategies. I'm not going to go into a lot of details. You'll be pleased to know about the maths behind here, but we look at different strategies for dosing. So, for example, whether we should boost every 6 months or every year. We look at the impact of these booster doses, and very much focusing on the immunogenicity of these fourth and subsequent doses. And we try to capture in the model the relationships that we see between neutralizing antibody titers and their decay over time, and what that means for both vaccine-induced immunity, but also the very broad spectrum of infection-induced immunity that most populations have now experienced, the so-called hybrid immunity. So just to explain a little bit about that, of course, both in vaccines and infection are boosting the immune response. We know when people are vaccinated, and we can measure very well what those neutralizing antibody titers look like. And those have been demonstrated to be quite a good surrogate marker of protection. So we can relate the antibody titers to protection against either mild disease or against hospitalization and deaths. What we know a little bit less about is how the exposure to infection is boosting those same titers, and in particular how those interact, how the vaccination on top of prior infection is boosting immunity overall. So to date, we're taking quite a pragmatic approach. We're just saying each is resulting in a boost, and we add these together. But of course, there's a lot of research that will need to go on into the future. And we then allow the decay of neutralizing antibodies over time and relate that to the decay in vaccine efficacy. And this is important in terms of thinking about how frequently high-risk groups in particular might need to be boosted, because we need to try and make predictions outside the first year or two of the vaccines that we've seen for how fast that efficacy is going to decay, particularly against the more severe endpoints. And then finally, as these variants emerge, we have to make some assumption about the degree to which they escape past immunity from either the older vaccines or from past infection. And we're doing that again by looking at the changes in the neutralizing antibody titers. So in fitting models, we've done quite a lot of work in trying to develop these models. We have a relationship in the model between the neutralizing antibody titer, shown here on the x-axis of these graphs, and what that translates to in terms of vaccine efficacy, which is shown on the y-axis. And so, for example, for a given level of neutralizing antibody titers here, we'll see that that would, for example, result in 50% protection against symptomatic disease or infection, but that same level would provide a higher level of protection against hospitalization and an even higher level against deaths. And this is, by using this model, we can capture what we observe in vaccine efficacy studies, which is a faster decay against infection or symptomatic cases, but that we tend to see that vaccine efficacy remains reasonably high against hospitalizations and deaths, at least over 6 to 12 months post dosing. And how we've obtained these is by fitting to UK-based data across England on vaccine efficacy estimates. So the types of fits we're looking at are shown in the blue data here. In the center, this is vaccine efficacy against mild infection cases, and on the right here is against hospitalizations. The blue data points are the data, and the black lines are the model fits. In the middle here for mild infection, and on the right here, sorry, for hospitalization. And we do that for different vaccine combinations. So you can see what I was saying in terms of the decay happening much faster against mild infection, but the efficacy sustaining at much higher levels against hospitalization. And doing the same work looking at the earlier Delta wave versus the Omicron waves, we can see that because of the degree of immune escape, we get quite different patterns and a much more rapid decay in terms of vaccine efficacy predicted against Omicron compared to what we would have expected against Delta. So this immune escape and this continual process that's going to keep happening is obviously going to be challenging and something we'll need to factor into future vaccine programs. We put these then into a population level model to try and understand what the future could mean in terms of what impact will this have, both in terms of circulating virus, but also on the demand on hospital care and ultimately in deaths. And we do this by trying to mimic what we think is happening with transmission in the absence of vaccination. And I'm sure most people by now have been quite familiar with this R number, the average number of infections generated from a primary infection. And we tried to mimic what was happening in different countries. This is a high income setting and a low middle income setting. We do something quite similar, where we see in 2020, what happened to that reproduction number R is that it dropped very quickly early on, and that's due to the lockdowns that were in place. And then these patterns varied over time with various introductions or social restrictions. But of course, from 2021 onwards, as vaccines have been introduced, we've been moving back to normal, and we think there'll be a constant level now of transmission in the absence of future non-pharmaceutical interventions. And we try to use this level to evaluate the benefit of continued vaccination. So we looked at a range of different vaccination strategies, really going on from the current time towards the end of this year and going forwards, and compared those to a baseline of just saying that we have mass vaccination with the 3 doses, but there's no further vaccination at all. And we can use that then to explore the value of vaccinating different groups. So here we would have cumulative doses would flatten out. We don't vaccinate any future individuals, whereas in the yellow here, we're boosting the whole population yearly. So you can see the number of doses given increases over time with each boost and another boost happening yearly, and so on. So these graphs are just showing different strategies that one might make. Obviously, as you boost more people, you're going to expect more impact. And so you want to try and evaluate these from a cost effectiveness purpose eventually to say, is it worthwhile? Do I get sufficient benefit from widening the vaccination program, or should I just focus on the highest risk age groups? So we put this into the model, and these results show what we might expect to see over time with these different vaccination programs. So focusing here just on the left graph, we see the past waves of infection. And as we, of course, the world opened up with Omicron, a much milder infection, we saw very large spikes in numbers of infections, not necessarily, of course, mirrored in terms of hospitalizations or deaths because of the presence of the vaccines. And as we go forward and introduce different vaccine programs, we can see this a gradual dampening of the waves of transmission until we get to some endemic level, assuming we just have Omicron, and in this it's an example of BA1 and BA2, but assuming we don't have very major jumps in the variants going forwards. The only place that we see a really big difference on the underlying levels of infection in the population is if we boost the whole population, so the 10+ age group yearly, shown here in yellow. And then we would see an indirect effect by having a lot of the population vaccinated. We would reduce transmission to much lower levels, and that's shown in the yellow. And that would provide an indirect benefit and reduction in risk to the highest age groups, in addition to the direct benefit that they'd be obtaining from being vaccinated themselves. More importantly, of course, to most health programs is looking at hospitalizations. What are the patterns likely to look like? And of course, with all these vaccination strategies and with the accumulation of exposure through infection, we would expect to see the same initial wave that we've already seen, but a dampening and different curves. And you cannot really see here, because of the scale, the difference between the different strategies. However, if we just summarize this in terms of the impact from middle of 2022 through to the end of 2024, we can start to see differences between these different strategies in terms of the total number of deaths, hospitalizations, or infections. So clearly the biggest jump occurs from not boosting to having some sort of booster program targeted at the highest risk age groups. And this second bar in purple shows boosting yearly to the 75+ age group. We don't see so much benefit in moving to 6 monthly vaccines. That's partly because we don't see too much of a drop off in vaccine efficacy over the first year of boosting, but clearly the yearly boosting is important. If we go to a lower age group, so for example to the 60+, shown in the orange here, you do get an additional benefit because the 60+ age group is still at a relatively high risk. At the boosting the whole population, most of this is an effect not of directly protecting those under 60+ age, simply because they're not at high risk of death, but it's the indirect effect of transmission that I showed. And you can see the drop off of the number of infections that's occurring if you do yearly boosting. So of course, most countries are really focusing on that direct protection where you get the highest benefit. We can also think of this in terms of efficiency. So translate this to the additional deaths averted per 100 additional vaccine doses, which of course relates to how cost effective a program is. And in this scenario, the higher numbers are more efficient because we're comparing it to no vaccination. So boosting the 75+ age group is the most cost-effective strategy. You're going to avert the most deaths per 100 additional vaccine doses. If you go to other age groups, it's less efficient, so it's less cost-effective. But this, of course, needs to be compared to the cost-effectiveness of other vaccine programs or other health spending. So if you add in the costs of the vaccine program to this, you can try to work out what that cost effectiveness threshold looks like. But regardless, always, if there's any limited supply, it's most efficient to target the older age groups or the highest risk groups. And of course, within that, although we don't have it in the model, high risk groups should also be included there. So one question, of course, as we go forward is, are we going to stay at an endemic level, or is there going to be ongoing mutations? So we have tried to look at this from a perspective like we see for influenza, where we see a gradual drift away from past immunity. And that changes things a little bit in terms of the dynamics over time. We'd expect to see much more wave-like behavior if we continue to get these mutations that are generating the small drift, as we are indeed seeing, I think, with the Omicron variant. And within that, we can start to look at the Omicron-specific bivalent vaccines that we've already heard about in the last talk. And it does seem that they were likely to have a greater impact compared to continuing with the original vaccine. But the relative impact is difficult to assess. So I think if those vaccines are available and they don't cost much more, then of course one would switch to them. But the switch is really going to depend again on the cost effectiveness metrics. And that will need to be decided within each country or within each vaccine program. The biggest concern, of course, for the public health community is that a new variant emerges, and we can't predict if this is likely to occur or indeed when it might happen. And of course, monitoring is in place to continue to look for these new variants. We've been lucky, of course, in the recent year, we haven't seen much of a big shift from Omicron, and now Omicron has pretty much replaced the Delta variant or many of the Beta variants and Gamma variants that were much more severe than the Omicron variant. But what we can do looking forward in a model is do some what if scenarios. So we looked at 3 different scenarios. In the yellow is a scenario where the transmission remains the same and we don't have too much further immune escape, but the severity itself just increases. The red shows a scenario in which there's additional immune escape, but the severity stays the same as for the Omicron variant. And the grey scenario is very much a worst case scenario where we would see both increased severity and immune escape. So we can compare the sort of patterns one might expect to see. And this makes evaluating a future vaccination program quite challenging. Because if you don't have the vaccinations in place, but suddenly you end up in a worst case scenario, you could end up with a very high epidemic. So the benefit really of vaccination is important. It is, as well as looking just at the co-circulating Omicron variant that we have at present, it's important to bear in mind that there is a perhaps low probability, but high potential risk scenario that could emerge from a new variant. And therefore, the benefits of vaccination need to take this into account. So just to summarize, if Omicron remains the dominant circulating virus, then we are likely to shift towards new endemic equilibriums, but we may have these wave-like patterns. Much has been discussed about the seasonality of this virus and thinking that it might start to look like influenza with our seasonal variation that we see. That does depend on how transmissible the virus is. If it continues in the same patterns, it's not necessarily going to be seasonal, but we may see that in a few years' time. What remains uncertain is what level of endemic infection prevalence we're going to arrive at. And it will depend on the vaccination strategy, but also on aspects of prior immunity that we don't fully yet understand. So research into understanding what hybrid immunity actually means is going to be important. Those worst case scenarios, whilst we of course hope they don't happen, are incredibly important to plan for. And of course, we've already seen the shift worldwide to BA4, BA5. There's a number of other subvariants that are being watched closely. And whilst that in itself is unlikely to cause a big impact in terms of immune escape, it may be that the shifting to the BA4, BA5 vaccines will become more important if that remains the dominant pattern. One of the challenges, finally, of course, is when we start to think of COVID vaccination as a more routine vaccination program, is how do we assess cost effectiveness? And everything I presented today has focused on the key metrics of hospitalizations and deaths, but it is important to bear in mind that we also need to capture the longer term effects of long COVID, We know this is affecting a younger population. We don't yet know what its sequelae and costs are going to look like over the next 5 to 10 years, for example. And there are these remaining challenges to say how, within a cost effectiveness framework, should one plan to account for these high risk variant outcomes that may never happen, but could seriously challenge the health system. Okay, thank you. I'll stop there.
Excelente presentación, doctora Azra.
Excellent presentation, Dr. Azra. You have given us the methodology that you are using and continue to use at the Imperial College in London to establish the value of vaccination in the high-risk populations. Current presence of the Omicron variant and the risk that it may generate in the short or long term with the presence of sub-variants. Among the studies you highlighted, a proposal that I consider of great importance is to have the population over the age of 75 as a target population with a high likelihood of dying or the risk of hospitalizations if they are not vaccinated in the period that you have considered that should be on a yearly basis. Also, you have also mentioned the study in this modeling to determine not only the levels of efficacy of the vaccine with the Omicron level or with other variants, the ones that have disappeared from the world, and you also emphasize the possibility that this pandemic will become an endemic, not seasonal, but with the need of monitoring to see at what moment there is an immune escape that will generate the risk of having an explosion of cases in areas where they've been very low vaccination rates, and also the presence in the extension of this new variant, if it should present. And finally, an important comment of keeping surveillance of these processes, specifically with this variant, and you recommend that in case of emerging BA4 or BA5 subvariant, we can use, depending from each government's decision and consideration from the Ministry of Health, the use of the new bivalent vaccines. Thank you so much, Dr. Azra. Please stay in the room so we can have a dialogue with the participant after the next presentation. Dr. Azra, you were very kind. Before continuing with the next lecture, we would like to greet all those who are connected and have joined us, who are participating throughout the world. At this moment, we have professionals that are following this webinar in Argentina, Bolivia, Chile, Colombia, Cuba, El Salvador, Guatemala, Mexico, Paraguay, Peru, Venezuela, and Ecuador. And also the institutions in the Ministry of Health of Peru, Chile, Colombia, Ecuador, and Venezuela, and health facilities from different areas, the Peru Navy Hospital, El Trébol Health Center, different health centers, the health office from Callao, Peru, from different national hospitals and these different public health institutions. Thank you to all the attendees. And we would like to thank all the questions that you have sent us and that soon we will deal with. Now we would like to extend a warm welcome to Dr. Ernesto Ortiz. Dr. Ortiz has a master's degree in global health with emphasis in global health and infectious diseases. He was a research assistant at the University of Iowa. He's currently senior manager at the Duke University Center for Global Health Innovation, where among his duties he oversees and coordinates research activities funded by prestigious institutions such as the Bill and Melinda Gates Foundation. And at present, with public health, with global leaders and national leaders from several countries in Latin America and Africa for the COVID Global Accountability Platform, COVID GAP, and for the rest of the Duke Global Health Innovation Center project. Dear Dr. Ernesto Ortiz, welcome, and you have the floor. Thank you, Dr. Bengolea. First of all, thank you, the Horas Conu, for the invitation and to share this with Dr. Azra and Dr. Minaya. Good afternoon. And what I'm going to talk about is to see trip in terms of the pandemic and to talk about the new priorities to maximize the global response to COVID-19. And for that, I will start with some background and context. As we all experienced during the first year of the pandemic in 2020, the countries were in emergency with health systems in crisis. Quarantines, total paralysis at the country level with economic generation. Countries started, responded in a slow and fragmented way. The inequality worsened worldwide in terms of access to health services, access to oxygen and treatment. And while this occurred, we saw the accelerated development of vaccines, and the pre-purchase were initiated. The vaccines were still under development, and the pre-purchases were already started. Together with this, we start at Duke University to monitor vaccines, the authorization, research, purchase, the manufacturing, donations, and we start to collect data and to do a real-time analysis. And we were able to see through this data and collection analysis that there was a significant inequality in the authorization, purchase, and production. And we were able to identify the bottlenecks in the manufacturing process. We start seeing changes time in different regions. We saw the inequalities in terms of purchase of vaccines, prepaid purchase, and in time, those inequalities got worse and were more prevalent. And in the meantime, The cases were still on the rise, new waves, new variants, and the inequity in access increased, and there was urgency to act, urgency to take action. There was a greater demand and supply of vaccines. High-income countries pledged to donate vaccines, but this not necessarily happened, and we saw that there was not many solidarity. Some nationalism start emerge in terms of vaccines, and we also saw of the infodemic was more prevalent. Lack of trust was more prevalent. And given this urgency of taking action, a group of experts from Duke University with other organizations related decide to start taking action, writing opinion articles, open letters to try to influence leaders worldwide. And we had a first call action in May of 2021 to the US Congress and administration, trying to establish a clear leader to coordinate a global response. The US with a more robust and sustainable response, share as many vaccines as possible to increase vaccine production and capacity worldwide, and support the improvement of vaccine distribution and delivery infrastructure, especially in low and middle income countries, and commitment to develop and implement a medium term to improve global vaccine production capacity. So that only a few countries manufacture vaccines, and that generated a supply problem. Time passed by, and in June of that year, we do another call to G7 leaders and to use the political, financial, and technological power of the G7 countries to increase vaccine production to rapidly accelerate equitable access to COVID-19 vaccines globally, and also to support low and middle income countries to increase their logistical capacity for the distribution and administration, and also addressing the issue of anti-vaccine misinformation. In August of 2021, another urgent call was generated to the US government to organize a global vaccine summit that was carried out at the end of that year, and to call upon and commit world leaders to vaccinate at least 70% of the world's population by mid-2022, that the US launched a global emergency plan to help reach the goal of 70%. While this was happening, in October of 2021, we launched a joint initiative with Duke University and COVID Collaborative, which is a platform of global responsibility against COVID, or the COVID gap. This is an independent initiative that searches collaboration throughout the world to monitor and generate ideas and recommendations that will collectively help to transparency and accountability, and to assume a global, regional, and country level responsibility in order to deal with the most urgent needs and comply and achieve the goals, and to accelerate the response to the pandemic. Also, one of priorities is to build collaboration and partnerships at global level with organizations, individuals, making emphasis in low and mid-income countries, and also be a independent source of information, knowledge, and do actionable recommendation. All of this done through collecting data, analyzing production and donations and distribution of vaccines, demand, and with this information collected through discussions with the collaborators and partnerships worldwide, issue recommendations, accelerate the response to the pandemic. That is how in December 2021, we did a first meeting in the middle of the Omicron variant. It has become a predominant variant in COVID gap. Call upon 70 and experts and leaders from all over the world. And as an output of this meeting, we issue a report called From Airport to Arms to provide new insights and urgent recommendations and to call on regional and national leaders in terms of vaccination tailored to country priorities, and also call on leaders on the countries to ensure an integrated government-wide approach with political leadership at the highest level and transparency and accountability to increase trust and acceptance of vaccination. We also look for an appropriate access to financing mechanisms for responding to this pandemic, establish immediate vaccination strategies that must prioritize speed and scale up of vaccination to address the bottlenecks that were identified, such as the cold chain, information systems, the health care personnel problem, and the demand generation. On April of 2022, there was another meeting with several speakers and more than 400 participants from all over the world. This meeting was co-organized with several institutions. Horace Condu, the Andean Health Organization, participated, in Cayetano Heredia University from Peru, and other global institutions. And in this meeting, we identify some priorities to be followed to satisfy the world needs in this new stage of the pandemic and build more robust, resilient, and equitable systems. And we issue a joint statement that indicates these priorities: accelerate equitable access and acceptance of vaccines, but not only vaccines, but also diagnosis and treatment in the future. Support country and community-driven goals and priorities, and to invest now to protect the future of everyone, everywhere from a pandemic, and promote accountability at levels and commit to global solidarity. Now, following this, we see the current status of the pandemic and what is the global response. A week ago, we heard Dr. Tedros, the WHO director, say that we have never been in a better position to end the pandemic, but we are not there yet. The end of the pandemic is in sight, but we're not still there. We need to continue and reinforcing our response. We've made incredible progress, have been made in record time. As Dr. Minaya mentioned, the development of vaccines, new platforms, and vaccine types were done in record time. There we saw world solidarity and funding. And this, so a large number of vaccines in less than 1 year have been able to distribute and apply to millions of people throughout the world in record time. But as Dr. mentioned, we're still not there. COVID continues to claim thousands of lives around the world. As in the Americas, 4,000 people die per week, and there's major inequities that persist to access to critical tools and resources. There are significant gaps in low and mid-income countries in terms of vaccination coverage. We see in graph 1 the gaps between the different countries according to their income level. And there's also an inequity in the distribution of the booster doses. As there's a large inequity to vaccine access and to the new bivalent booster vaccines and to oral antivirals that are highly effective that we have and have been tested and proven, as well as the test and treat to do this on time and use these oral antivirals that are effective. But we need to reinforce the capacity of testing in order to get there. But as we see, still the world is returning to normality. In the news, we can see that for many, the pandemic is over, that many countries are relaxing their measures. Well, we need to, the life continues and many have to reconsider priorities, paying attention to the other things that were unattended. Pandemic, address the economic and social impacts, the lost jobs, inflation, social impacts, the loss of education, impact on health. We need to recover the time that's been lost in maternal and child health, nutrition, anemia, non-communicable disease, mental health, cancer, diabetes. We see the issue on routine vaccinations schedule in children that has dropped significantly. In America, there's been a drop in almost every country. The coverage has dropped less than 80%. The Pan American Health Organization issued a message last week with regards to 12 countries in the Americas are at high risk of suffering an outbreak in children population, and to recover the workforce that has suffered so much, and to rebuild the health systems in a more resilient fashion. In the graph to the right, we see the drop in vaccination coverage occur globally, but low-income countries have suffered it more. So facing this new scenario, approximately a month ago, the COVID gap met with 30 leaders from the public and private sector from every region, including South America, included regional and global organizations to discuss priorities and plans for this new post-emergency phase in the pandemic. And based on these discussions and our independent analysis, we had this report about the new priorities to maximize the global response to COVID. First, the empowering and recognizing first the national priorities in each country. Invest more in regional capabilities and initiatives to provide technical assistance, coordination, and regional leadership in the current response to COVID-19 and future threats. A couple of weeks ago, precisely, I participated in a workshop organized by Africa CDC, and I was able to see how that region have come together, and they are discussing and sharing on all the countries, sharing their experience, challenges of issues they find in increasing their vaccination coverage and responding as a block. And another issue is to refocus the roles and responsibilities of global organizations to prioritize a better and effective coordination of regional and global responses, promote and encourage fundraising based on national priorities, on regional priorities too, and strengthen technical assistance. Then another recommendation is to immediately prioritize the full protection of vulnerable and high-risk populations, always in line with country priorities. We see that there are limited resources and several priorities that show at the same time to take a large amount of lives in the short term and to protect our fragile health coming waves or outbreaks. To the immediate approach has to be to high-risk populations. So we recommend complete immunization, including booster doses, those at increased risk of death or disability from COVID, elderly, the health workers, and people with and use available vaccines as much as possible. And if the data show, for example, with the case of the new bivalent vaccines, and to see if the data shows increased effectiveness of the new bivalent versions, the effort should be made to accelerate their access and equitable access to this vaccination, to this prioritizing always the populations at high risk, and to establish and scale up the test and treat capabilities, provide timely access to oral antivirals to the high-risk population to complement vaccination, and establish and monitor progress in the short term. Another topic was to strengthen real-time access to disaggregated data, to strengthen the information systems at national and international level to reach priority populations and to better monitor progress, to invest in strengthening public health data systems, which will help not only to the immediate response to COVID, but also to improve health system capacity to prevent, prepare for, and respond to future pandemics. Then, to integrate the management of COVID-19 with the national immunization program, to integrate health services, the national immunization program in managing COVID-19. We've seen that almost all countries have stopped their emergency response to COVID, but with no clear plan to include activity related to COVID, to integrate these activities to existing health facilities. While do this, they ensure proper prioritization of needs and more efficient use of resources, having a more efficient primary health care with competent and better paid health staff results in a more resilient health service and ready to deal with sanitary emergencies in the future. We need to urgently support efforts to recover and increase national childhood immunization coverage, as well as to mitigate the impacts of the pandemic on the care of adults. That also needs to create new mechanisms. The national immunization programs are mostly focused to children's vaccination, but we need to adapt new mechanisms to make sure the adult population to these vaccination programs. This also offers the opportunity to offer additional health information to that adult population, for example, screening for non-transmissible diseases, administer other vaccines to this age group, and also to invest in strengthening the health workforce, especially many countries are investing in community health workers, which are the link between the community and the health system, and also to provide and or improve compensation and incentive and the resources for the health personnel. And during this pandemic, we've seen a disruption in the production chain of medical products. We've seen the shortage of essential products for COVID response, for example, in terms of vaccines, PPE, oxygen, diagnostic tests, drugs, and we've seen how dependent we are from the producer countries. So we need to build in a sustainable manner the demand for regionally produced products and to long-term strengthening of pandemic response and prevention and to strengthen health systems. And therefore, something that we're doing in COVID gap is to promote that precisely, to these regional commitments, create regional manufacturing hubs, and to promote the regional response as a bloc that help to have better negotiation power and to develop joint purchase mechanisms, as well as to strengthen the regulatory support, strengthen the supply chain and the productive workforce, among others. I mentioned 2 weeks ago, I visited Africa, and during this workshop, I was very pleased to see how the region creating collaboration to manufacture vaccines in the region, something that we are promoting from COVID gap, promoting in Latin America at the regional level, the creation of hubs to strengthen this manufacturing capacity for medical products, vaccines, and be better prepared. That's it. Thank you. Apologize if I extended my time. Thank you. Thank you, Dr. Ortiz, for your excellent presentation. You have shown us what's something that we still have in our retinas, how the pandemic, how the world behaved in the pandemic and the impact in our population, in particular the Andean and South American population, where we were able to have at end of the year 2020, we had a very low number of doses and many didn't have access to vaccines. And at the end of 2021, we only had 11% of those vaccines. It is important to point out some aspects of your presentation with regards of how the university where you're working tried to organize through a platform with other institutions and stakeholders in calling for a review of the proposals to identify and improve the production capacity for vaccines in first place, and also to strengthen the information exchange that was key to provide an adequate response. And something important was to have a plan, a long-term plan that will allow establish goals for in any of those scenarios and characteristics of the pandemic in different areas of the continent. You mentioned from Latin America and Africa as scenarios of high importance in relations to different economic conditions and social conditions. Another thing that you mentioned is the recommendations that have been issued so we can structure a better care to COVID problem. One of the priorities is to do adequate dissemination of the characteristics of the process, but not only at the national level, but also at local levels, where you establish the priority that at this level, they will have a high capacity for responding. Among the recommendations, it was to prioritize on vulnerable groups, coinciding with our previous speakers, in the sense that the elderly are a group that may have the possibility of a high risk of dying or a more severe form of the disease. And among these recommendations, something important was the real-time access to information. It has been shown through different world platforms that have been used to identify the characteristics of the process, the age groups, and the population that have been affected. And we can do, and it's important to maintain these systems that allow a quick identification of the speed of the process. And a recommendation that we consider of high importance is that when we see the decrease in this process, we need to integrate COVID-19 vaccination in the regular programs of the Ministry of Health. And this is very important to have vaccines available that can be used in the populations that need the most, the ones of the highest risk, to reinforce immunization in the populations that most need, the most vulnerable. Those are who are immunocompromised, to the health staff is a first responder. Well, we thank your intervention, Dr. Ortiz, and we invite you to stay in the room for the Q&A. We invite everyone to have a moment of relaxation after this moment of learning and knowledge exchange. It is essential to take some time of relax and start a mini session of physical exercise during teleworking. Whereas Conju encourages the well-being of those who join us in this virtual session. And in these next few minutes, we will exercise with an active pose to stay healthy, combat stress, reduce work fatigue, and keep muscles flexible and healthy. Please go ahead with the active pose. There will be no English interpretation of this active pose.
Adelante, Rob, por la pausa activa.
Hola, hola, muy buenos días, buenas tardes desde el Organismo Andino de Salud y el Convenio Hipólito Unanue. Los invitamos a hacer esta pausa de relajación, un automasaje que te va a encantar. Siéntate, disponte de estos minuticos y empieza. Lleva tu cabecita hacia un hombro y hacia el otro. Empieza a dejar la relajación de tu cuello, de tu cuerpo. Inhala profundo, exhala, lleva la cabeza de adelante hacia atrás. La idea es que logres desconectarte unos segunditos de tu trabajo y puedas regalarte este pequeño automasaje. Lleva la cabeza hacia el hombro derecho, con la mano contraria vas a empezar a hacer punzoncitos desde el hombro hacia el cuello. Haces como si la mano caminara, punzoncitos con fuerza que realmente distensionen, todo el tiempo con inhalo por nariz, exhalo por boca. Eso es, de arriba hacia abajo. Ahora vas a colocar tu manita sobre el hombro y vas a empezar a hacer pequeños como pellizquitos del hombro hacia el cuello. Busca ese punto atrás de tu espalda que suele doler, que puede generar tensión y oprime. Esto también lo puedes hacer con un aceitico, una cremita. Ahí donde te encuentres, muy bien, regresa suave. Vas a llevar la cabecita al hombro contrario y nuevamente punzoncitos de arriba hacia abajo. Haz con la yemita de los dedos el movimiento, como caminando hasta el cuello. Inhala, exhala. Muy bien. Nuevamente manita sobre el hombro, pellizquitos de arriba hacia abajo. Intenta simplemente relajarte, descansar unos minutos. Haz movimientos acá en la zona del hombro. Masajeas, masajeas. Muy bien. Ahora vas a llevar tus dos manitas atrás del cuello. Vas a empezar a masajear y vas a hacer como que deslizan las manos de atrás hacia adelante, como si limpiaras tu cuello. Entonces, inhalo, exhalo, deslizo. Inhalo, exhalo, deslizo. Eso es. Ahora lleva tus manos hacia atrás. Mueve tus dedos de arriba hacia abajo, baja un poco tu cabeza y empiezas a hacer nuevamente los punzoncitos acá en toda la zona cervical, más que todo aquí donde inicia el cabello, masajea de forma circular. Este es un punto de tensión que nos ayuda a quitar dolor de cabeza, dolores musculares. Eso es. Masajea de arriba abajo. Eso, muy bien. Con las palmas, con la yemita de los dedos. Muy bien. Ahora vamos a terminar con un estiramiento que nos ayude a terminar de relajar. Mueve ahí los hombros. Lleva la cabeza hacia un hombro. Mantén ahí unos segunditos. Recuerda la respiración. Inhalo. Exhalo. Cambiamos, inhalo, exhalo, palmas en forma de oración, colócalas en el mentón y sube la cabeza. Mantén unos segunditos ahí, inhala profundo, exhala, ahora al contrario, hacia abajo, hazle fuerza con las manos, muy bien, regresa. Eso es. A todos los países, Bolivia, Chile, Colombia, Ecuador, Perú y Venezuela, desde el Orascono, les agradecemos por esta pausa de tranquilidad, relajación. Espero te haya gustado. Chao, chao.
Muy saludable.
Very healthy. Thank you so much. To start a dialogue based on the questions asked by the audience, I invite the speakers turn on their cameras during this webinar. We have received many questions. We will do our best to answer most of them. First question is to Dr. Patricia. Is the following. What is the effectiveness of Moderna's pediatric vaccines for children over the age of 6 months? We haven't evaluated the Moderna pediatric vaccine yet because that among all the available vaccines, the vaccines that we have recommended for those under the age of 30 are the Pfizer vaccines. So the Comirnaty vaccine. This doesn't mean that the Moderna vaccine is not fit or could not be proposed to the populations to which they have defined. It just means that in the French context, considering the vaccination coverage and the purchases done by the state, in our schedule, the recommendation is to prioritize the Pfizer vaccine for those under the age of 30. Thank you, doctor. Second question, what studies are being carried out to establish the vaccination schedule against COVID-19? Are they going to change according to age? Yes. And for that, the explanation of Dr. Azra Ghani was very interesting because we need to understand that the COVID-19 disease is a disease of a very high risk to the elderly. Among all the risk factors that are known, there are many chronic diseases such as cardiovascular diseases, diabetes, and other diseases. One of the factors that better explains the seriousness of the cases is age. There are very few diseases where age is such an important factor. And this can be explained by the fact that there is a loss of performance of our immune system with when you get close to the older group age. So the most important recommendations present, as Dr. Azra Ghani mentioned, we're not completely sure yet of how this pandemic is going to evolve and what are going to be the schedules that perhaps we will recommend in the long term. But today, nowadays, with the circulating variants, we are seeing that they're less virulent in the population that have high risk are the elderly. Yes, we can make a difference. And in any case, in France, a recommendation to provide a booster dose to those over the age of 60. And for those under the age of 60, we will vaccinate all of them who have one or more comorbidity factors. Definitely make a difference by age group seems to be appropriate. Thank you, Dr. Patricia. The question for Dr. Ghani. What are the risks the inequality represent in the access of vaccines against COVID-19?
Yeah, I think inequality is a big issue. And what we see here in the UK is vaccine uptake in particular is very different amongst different groups. We're also seeing quite a concerning drop-off in terms of vaccine uptake with the booster doses compared to the third doses even. So there's a bit of fatigue in the population. But what we also saw throughout the pandemic, and we've seen worldwide, is that certain groups are more exposed due to having to go to work or not being able to self-isolate early on. And due to things like overcrowding in houses and just being closer together. There's a whole load of factors that come in to put some groups, particularly those that have lower socioeconomic status, at higher risk. And that compounds, as Patricia's mentioned, with other existing health issues, which are also clustered by economic status. So there's a whole load of things that are driving this. And it really calls for a broader approach, again, to addressing the structural issues that are determining these, rather than focusing on a single health issue.
Gracias, doctora.
Thank you, doctor. The next question for you. There's no doubt that Africa is the most affected continent, and they set up the platform for technological transfer for mRNA, messenger RNA vaccines. What achievements have been done by this platform, and what is required to strengthen their outreach or scope?
Sure. I mean, so what we've of course seen, and not unexpectedly over the pandemic, is the hoarding of vaccines, particularly in those countries that can both afford to stockpile, but also, of course, have the manufacturing facilities in place. And that has led to an inequitable distribution of vaccines across the world. So we're very encouraged by the development and transfer of the technology of these platforms to the African continent and elsewhere, of course, because the greater diversity in terms of numbers of countries and numbers of groups that can develop the vaccines is going to, of course, give a much more equitable access going forwards. It's not, of course, straightforward to suddenly set up a large manufacturing plant and be able to manufacture at scale. That takes time. It takes training and education longer term. But by having this process started, we'll hopefully be in a much better position for future pandemics or future health threats.
Muchas gracias, doctora.
Thank you, doctor. And there is a request done by the audience, and it says, could you share the link of the study that you have presented? Dr. Asra?
I can share a slightly earlier version of it. I don't
Puedo
have
compartir una versión un poco más preliminar, si que desea. Thank you. Dr. Ortiz, what will be the economic impact in low and mid-income country in the negotiation of eliminating patents by the pharmaceutical companies? Thank you for your question. Well, this is a very difficult issue that's been under discussion since the beginning start, and I think that it's going to take a while. That is why one of the things that we're trying to promote is the coming together of regional blocks to have greater strength when we negotiate and when we want to develop manufacturing capacities to produce vaccines and be able to negotiate with the patent owners and negotiate with them to release those patents so we can manufacture the vaccines at the regional level. As I mentioned, something that has taught us this pandemic is the dependency in that the southern hemisphere has with the northern hemisphere, and the need to promote the dialogue and to share experiences between the South-South collaboration. We have many things to learn in our region, in the southern hemisphere, that we have similar realities and similar challenges. There's experience like we've seen in Africa, responding as a bloc and having this initiative to manufacture vaccines, that is well in progress. I understand South Africa, they started manufacturing vaccines and do this in a regional fashion. And I think that in Latin America, in a few initiatives, like they have found a lot of hurdles on the road. Mexico, Argentina with AstraZeneca or Brazil. But I think that vaccine production in Brazil and Mexico and Argentina didn't met the expectations or the goals that were established. And therefore, at that COVID gap level, we are trying to promote and to serve as a platform to promote that type of initiative between South and
Gracias, doctor.
Thank you.
Una segunda pregunta.
The second question, what have been the irregularities mostly seen in donation of vaccines among countries? What international policies are recommended? With regard to donations, what we saw is that firstly, many countries promised that they were going to donate a specific number of vaccines, but it only stay on the promise. And another issue that we saw that mostly in Africa, some donated vaccines had already very short time for expiration, and the supply chain could not provide the distribution of the vaccines to apply them in the time that remained before they. So many ended up being thrown away because of this issue with expiration dates. I think that happened in Nigeria, that they had to discard many doses. That goes together with the information technology of the health systems. By having a real-time information service, we can know where is the need of the vaccines and where to send it as quickly as possible, and be able to consider also that cold chain that was a bottleneck that didn't allow that donations to reach on time. Thank you to the speakers for their answer.
Agradecemos las preguntas
We
realizadas.
thank for all the questions. We're not able to respond all, but we will consider them to define the topics of the next webinars. And we value your participation and interest. To close this space, I would like to ask the speakers to leave us in 1 minute a final message or comment in the order of their intervention. Go ahead, Dr. Patricia. Thank you for the opportunity of sending a message from my experience and my scientific expertise. Message I would like to confer to you is that we live through a great revolution with the new messenger RNA vaccination platform, and the research has occurred with a very important number of volunteers, and that today, after more than 2 years of use, we can be sure that these vaccines are effective and safe, and that we can trust that they are a tool to use to continue to fight against the COVID-19 pandemic. And thank you very much for the invitation. Thank you very much, Dr. Vinaya. Dr. Asra, you have your final
Thank you
message.
very much. I mean, my first thing I'd like to say is, of course, thanks to all those public health officials that are watching this for all their efforts over the past 2.5 years. Certainly the level of vaccination coverage that has been achieved in the Andean region is fantastic, and really has helped to control this and protect so many lives. So thanks to all of those involved. Obviously, as we go forwards, we'll have to continue to monitor what's happening. It is, of course, challenging with the fatigue that the populations have now got to in terms of trying to respond to this continued threat. But I'm sure that with the continued input of all the people involved in vaccination programs, as well as the scientific community that will continue to keep developing the new updates to the vaccines to keep one step ahead of this disease, we can beat it and return to our normal lives. Thank you.
Muy amable, doctora.
Very kind, Dr. Azragani, for your final words. And now we invite Dr. Ernesto Ortiz. Please go ahead. Thank you, Dr. Bengolea, once again to thank for the opportunity to participate in this webinar. And I think that's something that this pandemic has taught us, in addition to the effects and impact on lives, economy, and health systems, is that the importance of having a strong and resilient health system and to have the health staff well paid, because as Dr. Azra mentioned, they are the front line in this battle, and we need to be sure to have a better paid health system with better tools fight this emergency, and also to focus on reinforcing the primary health care. It is there where we fight more the COVID and where we fight the cases. And once again, to reinforce the union, the bloc response, to share experiences among the countries, the regions, and to promote those initiatives to be less dependent of the Northern Hemisphere, trying to promote that to have a better response capacity and not depend and decentralize the response at the regional level. Thank you, Doctor. We reiterate our gratitude to our excellent speakers and to all attendees who accompany us week after week, to the Andean Health Organization team, and to all who participate in this activity, which has been possible thanks to the commitment to Andean and Latin American integration. I give the floor to Dr. Marisela Malki to close this webinar on behalf of the Andean Health Organization Hipólito Unanue Agreement. Go ahead, Dr. Marisela. Thank you, Lucho. First of all, we would like to express our gratitude to our extraordinary speakers, Dr. Patricia Minaya, Dr. Ganiatra, and Ernesto Ortiz, for sharing their knowledge, experiences in this topic that's so current and important as it related to vaccination and COVID. The pandemic that we are still dealing with has definitely large impact at global level, not only in health systems, but also in the economic and social sectors, in all the areas. And I think that the stronger systems have been also hit. And of course, the weaker ones are in the less been mostly hit. When the pandemic started, what we saw at the beginning was a great solidarity in sharing information. We had a genomic map at 1 week. And they started manufacturing vaccines. We were very hopeful, following the statement that vaccination was going to be massively applied. The world had never imagined to vaccinate more than 7 billion people at the same time, but that was a hope at that time. But in time, we start seeing that inequity in access, the solidarity of the beginning, become a lack of solidarity in nationalism that start to emerge, and a dependency of the less favored countries, of the countries that generated these products. well, 2 years and a half have passed by, and we've been dealing with this pandemic. We've learned a lot. We still continue to learn, following what Dr. Pedro from Pajo said. We see the light at the end of the tunnel, but we're still inside the tunnel. So we all are hopeful to waiting the end of this. But as each one of you have mentioned, this is going to come here to stay. And we continue having questions. We don't know what course is going to take, if we're going to have new variants, the vaccines are going to be applied, how frequent. We still have many, many questions. We've been witness of this revolution in research to have a vaccine in such a short period of time. But well, we still have regions and countries with very low coverage. Fortunately, on this side of the world, in our Andean region, as we mentioned, coverage is very large, significant, and fortunately, we have a vaccination culture and acceptance of vaccines that is wide compared to other regions, and has facilitated with the effort of our human resource is the most valuable thing that we've seen in recent times. Fortunately, that displays the care of other pathologies and the regular vaccination of children. WHO and UNICEF have issued that there's been a major reduction in cover vaccination with a great risk of reemergence of polio and other conditions. However, the countries with their culture, that they have their strongly organizing activities to recover and catch up this vaccination of our kids, and hopefully we will make progress in that regards. Our institution has an Andean vaccination committee that has activities in the 6 countries. Something that we are also promoting from our is the block response. I believe that that's one of the important learnings that this pandemic is leaving us, because we need and we are working in sanitary sovereignty. In this part of the world, we need to manufacture vaccines, antivirals, diagnostic tests, PPEs, which was so difficult to obtain at the beginning. Peru has the sad reality that we lost more than 600 colleagues, and other health professionals in our other countries also suffer this. And I think that we greet and we welcome what Duke University is doing with regards to continue having this adequate response issue on agenda according to the moment that we're living through, establish priorities, and we need to continue advocating funding for health, keep at the minimum kept, that instead they have an increase in funding for health, because we've seen that it has showed all our weaknesses. And if this is not a time to reverse this, it's going to be very difficult to do it later in the social determinants and structural problems that have to do with that. In that regard, something good that this pandemic brought is that other sectors, economy, labor, motion, foreign relationships, they all had to be around to what health indicated, and hopefully that could be maintained from now on. It is important to strengthen our health systems for a better response in the case of an emergency or catastrophe in the future. And unfortunately, it's not too far. And primary health care is definitely important from the first level of care, which should give the first response to that situation. And then we continue working. Once again, I would like to thank each one of you for your time, your presentation, and I'm sure that we'll continue in contact to work with this common goal that health is what first needs to be addressed and as a right to health. And in that, the Andean Health Organization works together with the 6 countries that are part of it. Once again, thank you. And to all our audience that follows us week after week in this space of learning, we invite you for the next Thursday, October 6th, 11 a.m., where we're going to see a very important topic, mental health post-COVID, which is a very important topic that we need to face. Thank you very much again.
Gracias.